You are lying on the dentist's chair, mouth open, eyes looking up at the ceiling, a tiny needle. 30 seconds later, half of your face is completely numb. The doctor cuts, pulls, and drills into your jawbone with sounds you hear crystal clear but feel nothing at all, and you lie there thinking about what to eat for dinner tonight. Seriously, someone is sticking metal instruments into your face, and you are mentally planning your menu. What just happened is one of the most important inventions in the history of medicine. Modern anesthesia has only existed since 1846. Before that milestone, there was nothing. But humans had been performing surgery for tens of thousands of years before that. They drilled skulls. They amputated limbs. They operated on abdomens. And patients survived, not dying from pain on the operating table, but living, recovering, walking, and living many more years. Archaeological evidence shows this so clearly that it cannot be denied. So what did they use? The answer is not one single thing. It was never just one thing, but an entire system, many layers, each layer even more astonishing than the one before it. And that system is right there in your medicine cabinet at this very moment. You just do not know where it came from. It starts with something that sounds like it insults prehistoric people, but it is actually just archaeology. Your ancestors were surgeons, not in a metaphorical sense, but in the literal sense. They cut into other people's bodies, controlled bleeding, treated wounds, and patients survived. Not once, not in one place, but continuously, systematically, across the world, tens of thousands of years before the word surgery existed in any language. In 2022, a group of 16 Australian and Indonesian scientists excavated Liang Tebo Cave in Borneo, a limestone cave with hand paintings more than 40,000 years old, and found the skeleton TB1, a young individual buried intentionally with red ochre earth placed near the lower jaw. When they analyzed it carefully, they realized they were looking at the oldest recorded surgical operation in human history. The left lower leg of TB1 had been completely amputated when he was still a child, 31,000 years ago. It was not an accident because the cut was cleanly diagonal across both the tibia and fibula at the same time, with no signs of splintering, no animal tooth marks, no signs of blunt trauma. This was the cut of someone who knew exactly what they were doing. But that is not even the most astonishing part. The most astonishing part is that new lamellar bone had completely regenerated covering the cut surface, meaning TB1 lived another 6 to 9 years after the surgery, grew up, moved around, and continued as a member of the community. Now put this in the right context. Borneo is a tropical rainforest, hot, humid, with microorganisms thriving at a rate that any modern surgeon would call a sterilization nightmare. A small cut on the hand in that environment, if not handled correctly, could cause a deadly infection within days. TB1 had an open cut going through 2 large bones in the leg, in the tropical rainforest, 31,000 years ago before antibiotics existed, and there were no signs of infection on the bone. That does not happen naturally. Someone did something very right. Someone understood enough anatomy not to hit the main artery when cutting, because if they did, the story would end in minutes. Someone controlled the bleeding, cleaned the wound multiple times over many days, and made the entire process survivable. There was no medical degree. There was no operating room, but they knew something, and TB1 was not the only evidence. More than 1,500 skulls from the Neolithic period have been found around the world, in Europe, the Americas, Russia, China, all showing signs of intentional skull trepanation, with estimated survival rates from 50 to 90%. In Spain 4,000 years before the Common Era, they found a skull with 2 drill holes on both sides, ear surgery performed twice, and the patient survived both. In France, 40 out of 120 skulls at a single site all showed drill marks. This was not some mysterious ritual, not a rare exception, but a common medical practice of a community. These people did not endure pain in desperation. They had a system. The question is no longer whether they performed surgery. The question is how they kept patients from dying of pain right there on the operating table. And the answer begins with one plant. The Sumerians called it Hul-gil, the joy plant. Not a poetic name, not the language of priests, but a name that appears in ordinary agricultural record clay tablets, alongside lists with wheat and barley. The Sumerians grew poppies systematically, harvested the sap from its pods, and traded it as a strategic commodity along trade routes from 3400 before the Common Era. This was not secret knowledge of a special group. This was common agriculture. But if you think the Sumerians were the first to discover this plant, then you are looking at the tip of a much larger iceberg. Researchers analyzing chemical residues in Neolithic European pottery have found biological traces of Papaver somniferum dating back to the 6th millennium before the Common Era, more than 2,000 years before the Sumerians. Not writing, not myth, but real chemical evidence embedded in fired clay. From there, the story becomes a non-stop geographical journey. Mesopotamia passed the knowledge to Egypt. Egypt passed it to Greece. Greece passed it to Rome. Rome brought it to Persia. Persia took it to India. Every civilization that received this knowledge continued to use it, expand it, and document it. That does not happen with things that do not work. No civilization continues to grow and trade a plant across thousands of years if it does not do what people need it to do. In Egypt in 1550 before the Common Era, the Ebers Papyrus lists 850 medicinal plants, and poppies top the list for pain relief. Egyptian doctors prescribed poppies for children crying at night in low, controlled doses, carefully documented in each case. This was clinical prescribing with specific dosage instructions, not ritual, not superstition, but systematic medicine practiced by people who understood that dosage makes the difference between medicine and poison. Now let us talk about why it works. Morphine in poppy sap acts on mu-opioid receptors in the brain and spinal cord, directly inhibiting pain signal transmission while activating a sense of well-being. This is exactly the receptor that Vicodin targets, exactly the receptor that OxyContin targets, exactly the receptor that fentanyl, the strongest painkiller in the modern emergency room, targets. Nothing has changed biochemically after 5,000 years. The molecule is still that molecule. The mechanism is still that mechanism. Only the name and packaging have changed, from hand-harvested plant sap to pharmaceutically labeled bottled pills. In 1804, the German pharmacist Friedrich Serturner isolated the active molecule from poppy sap, named it morphine, and declared it a scientific discovery. He was right chemically. He really isolated the pure molecule for the first time. But the Sumerians had been using that molecule 5,000 years earlier. The Egyptians had been prescribing it 3,300 years earlier. Serturner just gave it a Latin name and thought it was an invention. But poppies were not the only thing in their arsenal. There is another plant whose synthetic version you drink every time you have a headache, and its story is even stranger because it was rediscovered twice. The second plant begins with a man observing. Hippocrates, in the 4th century before the Common Era, recorded in the Hippocratic Corpus something he had seen enough times to believe in it. Patients who chewed willow bark had less pain. He prescribed it for women in labor pain, for patients with high fevers, not because someone told him it was a miracle remedy, but because he saw the results, recorded the results, and repeated the process enough times to consider it medicine. He observed, documented, and prescribed systematically. That is medicine even if it did not have that name yet. But what is truly astonishing is not that Hippocrates discovered willow bark, but that he was not the only one to discover it, and those others did not know he existed. Ancient Egyptians used willow bark for inflamed wounds. The Chinese used it for joint pain and fevers. The Cherokee in North America used it for headaches. The Assyrians recorded it in medical clay tablets. 4 cultures, 4 continents, with no contact with each other, all reached the same conclusion. People who chewed willow bark had less pain. That was primitive scientific method. Observation, experimentation, repetition, without a name for the process but working exactly like that process. In 1763, the English clergyman Edward Stone tested willow bark on 50 patients, sent a report to the Royal Society in London, and declared a new discovery. Hippocrates had done this 2,100 years earlier. In 1897, Bayer synthesized aspirin from salicylic acid, the active compound in willow bark. The mechanism is inhibiting the COX enzyme, reducing prostaglandins, reducing inflammatory pain and fever. Hippocrates did not know what the COX enzyme was. He just knew it worked. He was right 2,400 years before science could explain why. And this pattern repeats with many other plants. Mandrake contains scopolamine, which suppresses the central nervous system, causing loss of pain awareness. Today, scopolamine is in pre-anesthetic medications and the motion sickness patch you stick behind your ear. Henbane contains hyoscine, which reduces muscle spasms, preventing patients from thrashing during surgery. Today, hyoscine hydrobromide is still in modern anesthesia protocols. Belladonna contains atropine, which controls heart rate during surgery. Today, atropine is the standard cardiovascular emergency drug in every operating room and ambulance in the world. Ancient people did not know the names of any of these molecules. They just knew which plant made patients stop thrashing, which one made them fall asleep, which one made them stop reacting to the cut. They were right about the outcome even without the language to explain the mechanism. And knowledge that is right about the outcome is still completely valuable knowledge. But individual plants were only one part. Ancient people did something much more complex. They combined multiple plants according to a principle that modern anesthesia still operates on exactly the same way. Around the year 1000 after the Common Era, the Persian physician Ibn Sina described in detail in the Canon of Medicine something called the soporific sponge, a sponge soaked in a mixture of mandrake, henbane, opium, and wine, dried, stored until needed, then moistened with warm water and placed under the patient's nose before surgery. The patient inhaled vapors from that sponge and gradually lost awareness of what was about to happen to their body. Many people read this description and think it is medieval medical superstition. But look at each ingredient. Wine increases absorption of the active compounds through the nasal mucosa. Mandrake creates a state of unconsciousness. Henbane prevents muscle spasms, keeping the patient from thrashing. Opium controls pain. 4 ingredients, 4 completely different mechanisms, combined to create one single outcome. This was not coincidence. This was pharmacological design refined over generations of observation by people who did not have names for what they were doing, but clearly understood that each thing did one thing and together they did something much bigger. In China, the physician Hua Tuo used a herbal mixture soaked in wine called mephisin to completely anesthetize patients before abdominal surgery. The records of the 3 kingdoms document successful internal organ surgery with the patient completely unconscious throughout the procedure. This was not cutting a small incision on the skin but operating into the abdominal cavity, intervening in the internal organs, and the patient knew nothing until waking up. The exact formula of mephisin no longer exists because Hua Tuo burned all his books before dying in prison on Cao Cao's orders. A complete and effective anesthesia formula disappeared forever in one afternoon, and that is one of the greatest losses of knowledge in the history of medicine. On the other side of the world, the Inca solved a different problem with the same sophistication. In trepanation, Inca healers chewed coca leaves and dripped the saliva directly into the incision on the skull, creating local numbness with natural cocaine. It was not general anesthesia but local nerve blockade, exactly the principle your dentist uses when injecting numbing today. Synthetic cocaine was first used as a dental anesthetic in 1884. The Inca had been applying that principle hundreds of years earlier. Roman soldiers on the battlefield were given a mixture of strong wine, hemlock, and mandrake before amputations, not to boost morale but as a standard military medical protocol recorded in Roman army documents. When you look at all these systems together at once, one thing becomes inescapably clear. Modern anesthesia in the operating room today uses 3 separate components: a drug to cause unconsciousness, a painkiller, and a muscle relaxant. 3 types, 3 mechanisms, 1 outcome. Ibn Sina used 4 types of plants, 4 mechanisms, 1 outcome. Modern anesthesia also uses ketamine to create a dissociative state, where the patient's mind separates from the body, still partially conscious but not feeling pain, and that is exactly the state that the soporific sponge and mephisin created. They achieved that state with plants. We achieve it with synthetic chemicals. The principle is identical. Ibn Sina did not have a pharmacy degree. Hua Tuo did not have a laboratory, but both reached that exact principle through pure observation over many generations, and that principle is operating in your operating room right now. But there is one thing that is not a plant, not a chemical, but is a pain-relieving weapon so powerful that modern neuroscience still has not fully explained it, and our ancestors exploited it systematically without knowing its name. That thing that is not a plant and not a chemical is the patient's own brain. This is something that most documents about ancient medicine completely overlook, and that is a major omission. It begins with the fact that modern neuroscience has confirmed with fMRI. Pain is not a simple physical signal, but a brain-constructed experience created from input signals. The exact same physical injury, a calm person and a panicked person experience completely different levels of pain, not because one is weaker or stronger than the other, but because the brain is processing the exact same signal in 2 different ways. This is not philosophy. This is measurable biology. According to integrated information theory, one of the most seriously studied theories of consciousness today, consciousness emerges from the ability to integrate information simultaneously across many brain regions. Modern anesthesia targets exactly that integration process, making brain regions stop coordinating with each other. The first thing targeted is the thalamus, the relay station that receives sensory information from the whole body and forwards it to the cerebral cortex to become conscious experience. Inhibiting the thalamus cuts off the signal pathway before it becomes pain. Ancient surgical rituals, with rhythmic music, chanting, herbal scents, and the authoritative presence of the healer, were acting on that same stream of sensory information, intervening in the processing before it became full pain. This was not superstition. This was neurological intervention using environmental tools. And there is a more specific mechanism behind this. When the patient trusts the healer and trusts the treatment process, the brain activates the endogenous opioid system, producing its own endorphins and enkephalins, the brain's own morphine, measurable by fMRI and PET scans. It is not imagined pain relief, but real biochemical pain reduction that occurs in the brain triggered by belief. Acupuncture from 1600 before the Common Era is the clearest example, stimulating at specific points proven by fMRI to activate that same endogenous opioid system, not because the patient believes in it, but because physical stimulation at those points creates measurable neurological responses. Modern studies show the same painful stimulation. In a ritual environment with music and a reputable healer, patients report significantly less pain than in a neutral environment, even when they know it is an experiment. Ancient people did not need to know what the thalamus was, did not need to know what endorphins were. They just needed to observe enough patients over enough generations to realize that patients who trusted the healer recovered better. Patients prepared with rituals thrashed less during surgery. Patients who heard certain drum rhythms could endure longer. They repeated exactly that every time. That was the scientific method, without a name for it, but it worked for completely real biochemical reasons. But let us be honest about this, because this script would be irresponsible if it did not say it straight. But let us be honest about this. None of what has just been described means that system was perfect. The most fundamental problem was dosage, and there was no way to measure it accurately. Too little, and the patient woke up midway, went into pain shock, and died. Too much, and respiratory poisoning, death. There were no standard scales, no breathing monitoring devices, nothing at all. A skilled practitioner was someone who survived long enough to learn from the mistakes of those before them, and that meant there were people before who did not survive to draw those lessons. The second problem was that the concentration of active compounds in plants was unstable. The same plant species, grown in different soil, harvested in different seasons, extracted differently, the concentration could vary many times over. Without analytical chemistry, there was no way to know how much you were using until after you had used it, and by then it was too late. The third problem was that knowledge was not evenly distributed geographically. Each system only had what grew in its own climate zone. People born in regions without suitable plants simply had no equivalent options, but the biggest failures did not come from the natural limits of plants but from humans. In medieval Europe, many anesthetic herbs were labeled as witchcraft by the church, banned, and people who knew how to use them were executed. European patients from the 13th to 16th centuries truly had to endure pain with no support at all, not because the knowledge did not exist, but because it was deliberately erased. That was a medical tragedy that lasted for centuries and was completely avoidable. And even when the system worked at its best, post-operative mortality rates were still high, but not because of pain, but because of infection. They had no concept of bacteria, no antibiotics. This was the limit of knowledge before microbiology, not the limit of knowledge about pain. The pattern in every failure is always the same. Not that the system was wrong, but that knowledge was lost, cut off, forbidden, or buried with those who held it. The system worked when it remained intact, and that is exactly what happened to a large part of that knowledge. It disappeared. And we lost many centuries to rediscover it, only to realize it had been there from the beginning, in the plants that are still growing, in the principles that are still working. And this is the part where everything becomes truly interesting, because while we are talking about ancient medicine as something belonging to the past, the modern pharmaceutical industry is quietly doing something very specific, going back to search for exactly what our ancestors knew. Morphine is still the strongest painkiller in modern medicine in 2024, 5,000 years after the Sumerians grew poppies systematically. No synthetic compound has replaced it in effectiveness for severe acute pain, not for lack of effort, but because nature had already optimized that molecule over millions of years of evolution before humans found it, and our synthetic chemistry has not caught up yet. Aspirin is still one of the most used drugs in the world, billions of pills every year, 125 years after Bayer named it, and new uses in cardiovascular health and cancer prevention are still being discovered that even its creators could not foresee. Scopolamine is still present in the modern operating room as a standard pre-anesthetic component, and the patch you buy at the pharmacy to prevent motion sickness contains exactly that molecule, the molecule that Ibn Sina soaked into the sponge 1,000 years ago. Atropine is still the standard cardiovascular emergency drug in every operating room and ambulance in the world. These things are not historical relics. They are medical tools being used right now, today, in your hospital. And that is not even the most astonishing part. The most astonishing part is what is happening right now in the research labs of the largest pharmaceutical corporations in the world. They are hiring anthropologists, linguists, and botanists to go to tribes in the Amazon, Papua New Guinea, and the Congo Basin to document herbal knowledge before the holders of it pass away. It is not charity. It is not cultural preservation. This is pharmaceutical research and development with multi-million-dollar budgets because the pharmaceutical industry knows something most people do not. 25% of modern prescription drugs have direct origins from plants used in traditional medicine, not inspired by direct origins. Ancient knowledge is a treasure map, and those who know how to read that map are making a lot of money from it. So what is the truth? It is not that modern medicine invented ways to control pain. Modern medicine learned how to explain why what our ancestors did worked, isolated the active molecules, refined them, standardized the dosage so no one dies from taking too much, and called the whole process progress. The molecules our ancestors found. The standardized dosages we figured out later. The names we gave last. The next time you lie on the dentist's chair and feel the numbing needle on half your face, or count backward from 10 on the operating table and stop at 7, think about this for 1 second. Your consciousness is not something that gets switched off like a light. It is a process continuously assembled from billions of neural connections coordinating every millisecond. Anesthesia does not switch you off. It makes those connections temporarily stop coordinating, like puzzle pieces shuffled on a table. The picture disappears not because the pieces are gone, but because they are no longer in the right places. When the drugs wear off, your brain quietly reassembles each connection one by one, automatically, and you wake up without feeling a single second of that process happening. What is keeping you from feeling pain on the operating table has a history much longer than your civilization. It began with someone 31,000 years ago, in a cave in Borneo, with a stone knife, enough knowledge of the plants around him, and enough care not to want the child next to him to die from pain. We did not invent ways to control pain. We just learned how to name what our ancestors already knew. That knowledge did not begin in 1846. It just got a new name from then on. If you find what our ancestors knew about the human body even more astonishing than what we thought, then this channel has many more things like this waiting for you. Subscribe so you do not miss the next time we flip over another thing you thought you already knew.